to dive in a little bit on some of kind of the nuances in frontline treatment. So, Katy, I'm curious, as far as a delayed cytoreductive nephrectomy practice, I know, we went through the TKI era of saying there's no benefit to upfront nephrectomy, but what is your current practice? Are you doing upfront? Are you doing delayed? If you're doing delayed, what time frame?
Yeah, I think the answer is all across the board,
okay.
right? It's hard to say this is what we always do, right? I do think, there are select patients with, maybe the lung-only disease that's very small that Matt kind of described, where that patient's going to go on for a nephrectomy, right? If you think of that as the cytoreductive, concept from that situation. But I do think this delayed cytoreductive is huge right now, and you guys have just said the word cure like 5 times in the last however amount of time, and right, that's a cure, and then we're still dealing, potentially with this primary tumor. So if we start talking this word cure and you're getting it with IO or triplet or what that is, where does that time frame come in for that delayed nephrectomy, right? So I didn't answer your question from a time frame perspective, but I do think, to show that the disease is not that progressive of disease and the patient has good tolerability and you can do a period of time of stop, I don't think doing, a delayed cytoreductive nephrectomy is a bad idea. I think it's a good idea.
Yeah.
I don't know if your practices and your urologists are kind of leaning the same way. Yeah. I think one of the other concerns is, what is it going to be like operating, on these people after IO therapies? We have some experience, in other disease states at the same time, and I've heard mixed things, but I think it's fairly straightforward from a surgical standpoint.
And do you find, I was going to ask, I know sometimes we do a delayed cytoreductive nephrectomy and we're having a great response systemically, but maybe the primary kidney tumor is the thing causing the problem.
Sure.
So what percentage of time do you think you're doing a delayed cytoreductive nephrectomy because that's the primary site of progression? It's kind of an oligo-progressive disease versus they're in a near CR and we just want to get the kidney out.
Yeah, so maybe a quarter of the time or so.
Okay.
I don't know. I mean, I'm just kind of guessing that out of the air, but I definitely think we see those patients, right? Yeah. Those are the ones that you guys are seeing, and you call us up and send us back and say, hey, it might be the time.
Yeah.
Yeah, it's pretty fascinating watching how these kidney tumors evolve too, because it's right. It's not just a size reduction. It's often a change in like the internal characteristics of these tumors, and they often become much more cystic in appearance, but there's often, that nodularity that probably is the focus of like live disease. Mm-hmm. And I think, refining how we are looking at these tumors will be important for us to make more educated decisions in terms of who probably will benefit versus who has, very deep response there.
Sure.
But it's tricky because there are patients that we predict will likely not have much disease left that do, and
that's right.
I think we have to. My hope is that as we have better PET tracers and others, we may be able to have a clearer job of discriminating.
See what's happening to the primary.
Yeah.
While you're getting that cure, right?
Any difference that you see, and this might be too detailed of a question, but you were just mentioning that maybe sometimes the concern from a surgical perspective is, what are you gonna walk in or be in the operating room
sure, yeah.
to with after a treatment effect. So is there anything different known between operating after a pure IO regimen versus like an IO TKI regimen where you have the...
Yeah, I don't think so.
Yeah.
Overall, I think the biggest thing that comes to be, honestly, is, really the renal hilum is what you're always thinking about, right? Yeah. The vascularity, and really the nodal status, or if a patient had bulky nodes, I think is where that kind of sticks in and gets scarred in from a, technical standpoint. Okay. But I don't think, necessarily different.
Yeah, okay. And then, Matt, I wanted to pick your brain. We've seen last year and maybe some updated data this year as well, looking at each of the frontline regimens and how they perform based on site of metastasis. And so I know you have done and have a huge knowledge base, and I find it particularly difficult to treat patients who have bony metastatic disease. So if you have a patient in front of you and maybe it's bone-only disease, how do you think through that? They're having pain and...
Yeah, they are challenging cases, and I think what we saw from kind of the summary of the bone sites across most of these trials is that the IO-TKI, response rates and PFS very similar to the general population on the trial. So these studies, particularly with cabozantinib, with nivolumab or pembrolizumab, very, very active in bone. And I think, to me, the patients that have dangerous sites, I really think about kind of 5 areas. It's really, to me, it's brain, liver, bone, pleural effusions that are metastatic, and then patients with like peritoneal disease with ascites. Those are patients we really run into trouble with early. And those are patients I worry I really have a single shot in. And those are patients I'm going to either give cabo-nivo or lenvatinib pembro to. And if patients do not have those kind of risky sites, or if they have risky sites and are sarcomatoid, those are the patients that I'm going to give nivo-ipi to, because I think nivo-ipi really shines. You guys did beautiful work looking at characterizing the sarcomatoid and the rhabdoid and just showing how they do have some biologic differences between the clear cell. But I think the patients that are going to fly through are going to be really enriched in those dangerous sites of disease.
And do you think there's something special about the signaling from the TKIs that have a broader TKI profile rather than like a pure VEGF profile that's the benefit that we're getting, or from a biologic standpoint?
So we did some animal modeling on this, and we did look at axitinib, cabozantinib, and lenvatinib. And both cabozantinib and lenvatinib do appear to have kind of a different way of modulating the bone. They actually can stop or at least temper down osteolysis in bone. And I think that this is really unique, and they do appear to interact differently with macrophage populations and then also your osteoblast, osteoclast populations. And so I do think that there is something unique about how both of these agents perform in bone. And we're trying to unravel the IO component to it, and the modeling in mice has been challenging for a long time. But we're hoping that we're getting to a point of overcoming some of those challenges, and we're doing a very deep dive into single cell sequencing and other of bony mets and kidney. So hopefully more to come soon, but it's a big area of research. Patients really suffer with a lot of pain and skeletal related events, and I think a lot of the bone met patients that end up on trial are a little bit different than the bone met patients in our clinic, because a lot of our bone met patients in clinic have really impaired performance status and challenges that make them very hard to enroll on study.
That's a good point. And then before we leave frontline treatment, I want to ask David, what do you think is most exciting to you, either at GU ASCO right now, or just there's been a ton of publications in the last couple of months on translational work, yours included. So would love to just hear where you think we're at as far as like biomarkers.
So I think, there's certainly some exciting developments, and I think at GU ASCO, KIM-1 has got to be probably the most well-developed. That idea that, again, it's early days, but maybe we could actually have this dynamic biomarker where we could know pretty early on, is someone going to do great and sail through with ipi-nivo, or someone needs really treatment intensification? I think that would be, if that validates, would be a really just tremendous addition to the field. The rest, the honest truth is, I don't think the rest are ready for prime time, but I think they provide really valuable biological insights. So I think there's a couple ways to look at biomarkers. One is trying to choose the right drug for the right patient, and I think that's really important. The other is to say, what is the biological insight where we can really understand the patients who do exceptionally well, what are those characteristics, and how we can sort of drive the biology towards that state. And I think that's the other thing I'm sort of excited about. If we can really understand, it's tertiary lymphoid structures, it's these sorts of things that guide exceptional responses, maybe that can inform in a rational way our design of new trials and new agents that are going to skew towards those sort of positive phenotypes.
That's great.
And I just want to add to Matt's comment. I think one of the more challenging things you talk about is brain mets, right? And so how do we treat brain mets? They've been excluded from all the clinical trials. So I actually think this meeting, one of the more interesting trials, albeit small, was we actually have prospective data now for cabozantinib in patients with brain mets. We had nice retrospective data showing this over 50% response rate, and now we have prospective data showing over 60% response rate in the brain with cabozantinib in patients with brain metastases. So I think that, to me, is very practice reinforcing, and I think hopefully it should be practice informing for a lot who aren't using these TKIs. I mean, I think Nivo-Ipi, it just, with renal cell, with the dose of Ipi we use, I just haven't seen any responses in the brain to the same extent. And so I think now we have this pretty compelling data, I think, for cabozantinib in CNS metastases is great. And I think it begs the question is, we probably need to be looking at all the TKIs in the brain. Like, is there something unique there? And so I think further trials saying how can we do better are going to be really critical, because that is a very much unmet need, which we don't have a lot of data.
And there were everyone was terrified of the bleeding risk, and
Right.
it was not seen. So I think size and symptoms and seizures and all these things have to be taken into account. But hopefully we now have the courage to continue to work forward. We do have an ongoing study, which is the triplet of Cabo, Nivo, Ipi, that my partner Jianbo Wang has been leading for a long time. They're hard though, because de novo brain met patients are relatively rare. And most patients that develop them kind of during their disease course, but not necessarily right up front.